Welcome back to the Neonatal Critical Care NPS review section on cardiology. Today is part 2, heart development. So first up is cardiac output. That is your stroke volume times your heart rate. That's the volume of blood ejected by the heart in 1 minute. Normal is 120 to 200 milliliters per kilograms per minute. We have a couple factors that are going to affect our stroke volume. So we have heart size, gender, contractility, duration of contraction, preload and afterload. And factors that affect our heart rate are things that are either going to make your heart rate go up or down, and that's going to have a change on your heart rate or your cardiac output. Next up is preload and afterload. So preload is the volume of blood in the ventricles before heart contracts. Afterload is the resistance of blood leaving the ventricles, and this is dependent on systemic vascular resistance and pulmonary vascular resistance. Next up, we're going to be discussing embryonic heart formation. This is going to tell you a little bit more about how the fetal heart actually develops. The primordia of the heart are identified as bilateral, symmetric heart fields derived from the lateral plane of the mesoderm. The primordia migrate through the primitive streak between the ectoderm and the endoderm layers to become symmetric mesoderm regions on either side of the primitive streak. These factors fuse cranially to form a tubular structure comprised of an inner layer of endocardium, a thick layer of extracellular matrix, and an outer layer of myocardium. The simple tube begins to contract rhythmically as it grows, so the dilations and constrictions appear on its length. Later additions of the distal ends of the tubular heart form the outflow tracts and the sinus venosa. Dextral looping of the two bring the venous caudal portion to a more dorsal position, and to the left of the atrial cranial portion a septation of the tubular heart begins. The epicardium arise from the tissue dorsal of the heart at the level of the atrioventricular junction and spread over the outer surfaces of the myocardium as a layer of squamous epithelial cells and associated connective tissues during the early phase of septation. Alright, now cardiac looping. Looping of the heart tube allows the straight end of the heart to form a more complex structure reminiscent of the adult heart. Most cardiac looping occurs during the 4th week and completes during the 5th week of development. The step in looping can be summarized as a straight heart tube begins to elongate with simultaneous growth of the bulbous cordus and the primitive ventricle. This forces the heart to bend ventrically and rotate to the right, forming a C-shaped loop with a convex side situated on the right. The ventricle bends caudally, and the distance between the outflow and inflow tracts diminishes. The atrial and outflow poles converge, and myocardial cells are added, forming the truncus arteriosus. Hence the S shape is formed, with the first bend of the S shape being the large ventricle bend, while the bend at the junction of the atrium and the sinus venosus form the second bend. Next up, we have septation. We have divisions of the atrioventricular canal. So the two endocardial cushions form on the dorsal and ventral sides of the AV canal, referred to as the superior and inferior cushions. The cardiac jelly in this region expands while mesenchymal cells from the endocardium invade the cushions, allowing them to grow and fuse. This fuse divides the common AV canal to the right and left canals, hence partially separating the primitive atrium and ventricle. Two smaller endocardial cushions also form on the lateral walls of the AV canal, which later help to form mitral and tricuspid valves. So septation of the atria. Membranous tissue formed the septum primum grow on the roof of the atrium, dividing it into the right and left halves. The space between the septum prima and the endocardial cushions is referred to as the foramen primum. Apoptosis-induced perforations appear on the center of the septum prima to produce the foramen saccadum. At this point, the muscular septum saccadum grow immediately to the right of the septum prima and gradually overlaps the foramen saccadum. During the 5th and 6th weeks of development, the incomplete partitioning of the atrium by the septum saccadum forms the foramen ovale. Blood flows from the right atrium through the foramen ovale and the foramen saccadum to the left atrium, forming a right to left shift. The remaining portion of the septum primum act as a valve of the foramen ovale. Blood cannot flow in the opposite direction as the muscular strength of the septum saccadum prevent prolapse of the septum primum. Next, there's remodeling of the inflow tract and the atria. The development of two left-right shunts in the venous system lead to an increased size of the right horn of the sinus venosus and consequently a decrease in the left horn by the end of the 4th week. The sinoatrial orifice correspondingly shifts to the right, thus becoming located in the right atrium. Hence, the right atrium receives the superior vena cava and the inferior vena cava in the adult. The left sinus horn regressed to form the coronary sinus in humans. Thus, the sinus venosus gradually becomes incorporated into the right atrium. It contributes to a smooth-walled part of the adult right atrium referred to as the sinus venerarum. The trabeculated right atrium corresponds to the primitive atrium. The divisions between these structures is indicated by the inner Christus terminalis and the outer succulus terminalis. The primordial pulmonary vein develop on the dorsal wall of the left atria. As the atria size increase, it incorporates more of the branches of the pulmonary vein, accumulating in its receiving of the 4 pulmonary veins. The smooth wall of the adult left atria originate from the primordial pulmonary vein, while the trabeculated wall represents the primordial atrium. So now we have septation of the ventricles. Minor trabeculations appear during early development of the primordial ventricle. Following growth of the ventricles and further trabeculations appear and grow as larger muscular structures. However, the more commonly described theory of septation begins with the appearance of a primordial muscular interventricular ridge developing in the floor of the ventricle near the apex. As either side of the ventricle grow and dilate, their medial walls fuse, forming a predominant IV septum. The foramen located between the cranial portions of the IV septum and the endocardial cushions. The IV foramen close by the end of the 7th week as the bulbar ridges fuse with the endocardial cushions. So outflow tract divisions, active proliferation of the neural crest Mesenchymal cells in the bulbous cordus during the 5th week create bulbar ridges, which are continuous in the truncus arteriosus. The neural crest cells migrate through the primordial parix over the aortic arterioles to reach the outflow tract. The bulbar ridges undergo a 180 spiral to create a helix atriocopulmonary septum. As the ridge grows and develops myocardium, they fuse in a distal to proximal direction. Fusion occurs during the 6th week, allowing for cleavage of the aorta and the pulmonary trunk. The spiraling nature of these ridges causes the pulmonary trunk to twist around the aorta. Note that the bulbous cordus accounts for the smooth conus arteriosus in the right ventricle and the aortic vestibule in the left ventricle. There are 4 valves in the adult heart. There are 2 AV valves which comprise leaflets as well as the structures that tether these leaflets to the ventricle walls. The aortic and pulmonary valves, termed the semilunar valves, are located in the aorta and pulmonary trunk respectively. They are each made of 3 cusps. The AV valve begins to form between the 5th and 8th week of development. The left AV valve has an anterior and posterior leaflet and is termed the bicuspid or mitral valve. The right AV valve has a 3rd small septal cusp, thus it is called the tricuspid valve. The valve leaflets are attached to the ventricular walls by thin fibrous cords, the chordae tendiae, which insert into small muscles attached to the ventricular wall, the papillary muscles. These structures are sculpted from the ventricular wall. The semilunar valves are formed from the bulbous ridges and the subendocardial valve tissues. The primordial semilunar valves consist of mesenchymal core covered by endocardium. Evacuation occurs, thinning the valve tissues, thus creating its final shape. That brings us to the end of this section.